Thank you for giving me an opportunity to present today. Here are my disclosures. But what I really want to disclose that I've been reading and learning from Dr. Merola's research since starting rheumatology fellowship. And I owe my knowledge of prevention to psoriatic arthritis on his published work. So let's start with understanding that why psoriatic arthritis prevention is important. Because once the disease sets in, only about half of our patients achieve ACR 50 response. That is 50% improvement in their tender joint count, in their swollen joint count, in their global assessment of the disease and CRP levels. An even lesser number of patients achieve MDA, that is minimal disease activity. And about 40% of the patients attain partial response or fail to respond at all to immunomodulating therapies. So that means half of our patients stay disappointed with this disabling disease. So the question definitely arises that what can we do to help our patients? And hence the concept of prevention comes into play. This figure represents the transition of psoriasis to psoriatic arthritis, which can take up to 10 years. So today we're going to discuss measures that we can take both in asymptomatic phase or symptomatic phase to prevent this disability. Starting with the risk factors, it's important to identify them. I'll start with the study published by Dr. Merola and colleagues that showed disease severity defined by treatment class, weight, more than 90 kgs, female sex, age group, and rheumatic symptoms such as pain are linked to development of PSA. We will discuss this study in details later on in the presentation. From retrospective study, let's move to prospective study. Today's debate is a lot going to be about retrospective versus prospective data. So for every measure, I will present both retrospective and prospective data. So this study was done in UK of psoriasis patients who were randomly selected between 2008 and 2011. And 10K questionnaires were distributed, and about 90% of these patients had confirmed psoriasis. And about 10% of these patients had severe psoriasis. And these patients were followed prospectively for the development of PSA. And the incidence was 5.4 cases per 1,000 person years. And after adjusting for age and sex, they found that BSA more than 10%, which is severe psoriasis, obesity, and depression was linked to development of PSA. Another prospective study from Toronto, where 51 out of 464 patients developed PSA, and during 8 years since enrollment. And the incidence in this study was 2.7 cases. And they found severe psoriasis, low level of education, psoriatic nail pitting, and uveitis to be linked to development of PSA. And this is a systemic review and meta-analysis also presented by Dr. Song. They showed that obesity and physical trauma are only two clinically meaningful factors that can lead to development of PSA. So you've seen these various study designs, and of all these designs, we can identify at least one risk factor that we can hopefully control and help our patients, and that is obesity. So let's see if we can intervene at this stage, at the high-risk obese stage, and help our patients. This study is a retrospective review done in UK, where 1,400 patients developed PSA of 90,000 psoriasis patients. They were a little less males, about 42%, with a mean age of 51 years. And what they found was higher the BMI, more was the risk for developing PSA. And reducing BMI over a 10-year period led to reduction in the risk of PSA. Now, a prospective study. This was done, what they looked at is effects of weight loss treatment with very low energy diet on disease activity in PSA patients. And these patients were obese with the BMI of more than 33 kg per meter square. And 41 out of 46 patients completed this study, and there were a little bit more women, 63%, with a median age of 54 years. The median weight loss in this study was 18.7 kgs, which is about 20%. What they found was larger weight loss resulted in more improvement in a dose response manner in the disease outcome measures, as you can see in the figure. And MDA, minimal disease activity scores, improved from 29 to 54%. So a lot of us believe in prevention of psoriatic arthritis. That's why there's so many international efforts being taken, including the Psoriacast app by Dr. Merola.
That's fine, Wayne. Yeah, next time,
Be careful.
yeah. Maybe I'll feel better now, though. I'll in a brighter room.
All right. Moving on to the next stage. And this is the subclinical stage. This is the stage where patients have radiographic evidence of inflammation, but not clinical psoriatic arthritis. This study was done in 162 patients with plaque psoriasis and 60 age-matched controls. This was done in 14 centers. And what they found was synovitis, which is inflammation of your synovium, and enthesopathy was significantly more in patients who have psoriasis as compared to controls. Another study of 73 patients with PASI more than 10 and 23 healthy volunteers underwent ultrasound for subclinical enthesitis. And these patients did not meet Casper criteria for PSA. So this is the subclinical or the preclinical stage. Half of these patients had at least one enthesial abnormality, with mean inflammation scores were significantly more in psoriasis patients than healthy volunteers. And after treatment with ustekinumab, the inflammation scores improved. And as you can see in the figure, the inflammation improved, but the chronic damage scores remain the same. So the controversy about this study is that patients might have already developed psoriatic arthritis. But here I want to bring you the definition of primary prevention and secondary prevention. So primary prevention is reduction or control of causative factors for a health problem and includes reducing risk factors such as obesity. But what is secondary prevention? Here, the disease is detected and treated early, often before symptoms are present, thus minimizing serious consequences, such as mammography for detecting breast cancer and ultrasound or MRI for detecting PSA. This is another article from Dr. Merola that shows the transition of psoriasis to psoriatic arthritis. And in this article, the subclinical stage is the stage of evidence of radiographic inflammation, and this stage is a stage prior to development of clinical PSA. And please notice the first word of this article, preventing. Now let's talk about the big PAMPA trial that is being conducted by all the experts in the field of psoriasis and psoriatic arthritis. Many of them are present in this room. This is a randomized, double-blind, placebo-controlled, multi-center trial. I cannot tell you how many times the word prevention was used in this paper. I have some quotes. The first one, the first step in prevention is to identify populations who are at risk for PSA. And this is a prospective randomized controlled trial to investigate the efficacy of gazalkimab in preventing the development of PSA. And they include in patients who have power Doppler ultrasound abnormalities. So my impression of reading this paper is that they think that patients with abnormal imaging is a stage prior to development of PSA. The study that I just mentioned, the PAMPA trial, it is a prospective study, but Dr. Marola, prospective studies have limitations too. And the limitation of that study is the timeline, just 2 years. Speaking of limitations, here are some early intervention studies. There are so many of them that I've stopped counting. But the first 3 were done by Gissondi, Acosta, and Rosenthal, and they showed that the patients on biologics took longer time to develop PSA than patients on non-biologic therapies. Whereas the study done by Mir and colleagues showed that the patients on biologics developed PSA quickly. Here I bring in again a study from Dr. Marola, the first one that I presented. This study was done to look at the incidence and prevalence of PSA, and what they found that patients on biologics had higher incidence of PSA. Here are a couple of quotes from the study. The first one, the use of systemic medication can be considered a surrogate for psoriasis severity. And because our data were limited to patients with EHR data, the results may not be generalizable to wider population. We all know about limitations of retrospective data, including misclassification, confounding by indication, allocation, channeling bias, collider bias, protopathic bias, and Dr. Marola will go over them in details with you, I won't. But it is very important to recognize the direction of bias. In these studies, it favors towards high incidence of PSA. So given the discrepancies in these studies, we conducted a trial where we compared biologics to each other, hoping that they will have similar severity. What we found was that patients on IL-12, 23, and 23 inhibitors took longer time to develop PSA than other biologics. And these results have been replicated many times, including this newer retrospective observational study, which was done in bio-naive psoriasis patients who took biologics continuously for 6 months. 622 patients were analyzed, out of which about 70% were males with a mean age of 46.9 years. And 60 patients on biologics developed PSA. And guess who were the winners? Which biologic class was the winner? It was IL-23. All these studies are retrospective studies, I agree. They all have limitations. And something that really bothers me is that IL-12, 23, and 23 inhibitors are considered less efficacious for PSA, and they could have been prescribed less for patients who have suspected PSA. But if you look at the trends of prescription over the last few years, IL-23s are being prescribed by dermatologists more than ever before. Here I want to talk about the Bradford-Hill criteria. Dr. Serrano also presented this, that causal relationship between an observed effect and presumed cause in observational studies can be established if there is plausibility, consistency, temporality, and biological gradient. Here I want to talk about biology a little bit more. Why IL-23 inhibitors? Is it due to the resident memory T cells, which are implicated in recurrence of psoriasis skin lesions in previously affected areas, and in the circulation of patients with PSA more compared to patients with psoriasis alone? And IL-23 is implicated in differentiation, expansion, and survival of TRM cells. Intervention by IL-23 inhibitor at the stage of enthesitis could delay the progression to PSA by reducing this TRM population. I'm sure you're all aware of the GUIDE trial. This is the study in which patients were initially prescribed gazalkimab every 4 weeks until they achieved PASI 0 or super responder status, and at least at week 20 or 28. They were then re-randomized to gazalkimab every 8 weeks and every 16 weeks. And once they achieved PASI less than 3, they underwent withdrawal of gazalkimab. And what they found that the patients who had ultra short disease duration of less than 15 months, about 40% of them stayed treatment-free after the last gazalkimab injection. Also, the knockout study, we have the author here in this room. This is the double-blind, single-centered study of risankizumab, 300 versus 600, and until week 16, and no dosing thereafter. What they found was that on week 52, the higher induction of doses of risankizumab led to higher levels of skin clearance, prolonged disease remission, and reduction in TRMs. So we, of course, need to validate these findings, but how are we going to do it? PAMPA study is not going to answer the question of which biologic class is better than the other. An adequately powered randomized controlled trial of sufficient duration is likely to be prohibitively expensive. What we can do is maybe a pooled analysis from the existing head-to-head trials. And here I've listed a few trials that can be looked at, and we can see the development of PSA. So in conclusion, if I'm wrong, then the contrary hypothesis is that the patients with psoriasis who are being treated with the medications that treat psoriatic arthritis effectively will have higher risk for developing psoriatic arthritis. I can't wrap my head around this. Thank you.